Good afternoon. I'm really pleased to be here. I'm very pleased that the Institute of Medicine invited me to participate in this discussion, despite the reputation I have in some Washington circles, at least, as being somewhat of a contrarian. Although it occurred to me that that reputation might have to do with the fact that I'm the 20th of 20 speakers today. I want to start off by saying that I'm very excited by and very strongly in support of the panel's basic recommendations and its basic thrust. This is an area in which I've actually done some work myself over the years. But someone who spent I counted at one point, I remember, someone who spent 1,565 days, but as the old punchline goes, who's counting as administrator of the Healthcare Finance Administration. I don't think one of them went by without somebody telling me they had a surefire way of saving Medicare money. And most of the time, they were wrong, or they were right, but it was illegal. And so I bring a certain skepticism to some of these conversations and even to some of the reported data, frankly. But I more importantly, I think it's very, very important to remember that payment systems are not the only policy tools available to governments. And that, in fact, if we're talking about integrated care, we need integrated strategies for improving that care and developing integrated care. There's a certain amount of interdependence associated with that, which I'll illustrate in a few moments. I think our experience with quality improvement and pay for performance increasingly suggests that, in fact, financial incentives are not the most effective way to improve quality on a sustainable basis over a long period of time. And I think in that regard that the centrality of the report's recommendations about changing professional practice and culture really can't be emphasized enough. And in fact, as I was listening to the conversation a little bit earlier, I was reminded that some of us have spent 25 or 30 years trying to provide integrated health and social services to people in the community-based long-term care system. I myself chaired the board of a managed care plan that sought to do so for 5 years. And the major barrier to effective integration of medical and social services in that context, and in many other such efforts, mostly unsuccessful over the last 25 years, has been the total ignorance and indifference of physicians towards community-based services for their elder patients. So not only could you not find them to write an order or an authorization when they needed it, or to change a script when the community-based worker understood that there was a change in the patient's condition, but you could laboriously provide social services to improve function or emotional well-being over a period of weeks or months, only to have it all be blown up and go out the window with the next visit to the physician's office. So we have to start with sort of value change and culture change among clinicians. I tried myself on at least several occasions to change physician behavior by changing payments, and never succeeded at achieving the goals I certainly wanted to. I want to re-emphasize David's point that as a growing number of Medicare beneficiaries who die not in hospice are enrolled in Medicare Advantage plans, and as the ACOs continue to expand, we have a natural laboratory for what makes sense in terms of expand. Those programs can provide any services legally that they want to. And if they think it makes good clinical and economic sense, you would suspect they would. I suspect they don't, because it comes out of the pockets of their clinicians under a capitated rate, and the clinicians aren't going to want to share it, even if you can show them better rates one side or another. But again, we have that empirical test going on, and we ought to study it, and the report recommends looking at it, but we should study it much more systematically and much more closely. I totally agree on the need to redefine the Medicare hospice benefit. I would probably have more radical proposals than some of the other folks. I think we ought to just do away with it as an alternative to conventional care and just make it a wraparound benefit for the rest of the Medicare benefit package. If we're going to do that, we have to significantly improve the quality standards and the enforcement of quality standards for Medicare certified hospices, and we have to come up with a better way to pay them than the current per diem systems. I think they may be the last providers in the world getting a per diem-based payments of one sort of another. And the place where I would differ, I think, from everyone else is I think the rational policy, which means that it's totally impossible, particularly in the current Washington environment, would not be to provide hospice service in nursing homes. It would be to expect nursing homes, given what they are and who they serve, to be skilled and capable of providing palliative care and hospice services themselves, and change those conditions of participation and make sure they were adequately reimbursed in order to provide those services. That's be a much more rational solution, and therefore, as I say, probably completely impractical. But I want to spend just a couple of minutes on what really is the thrust of some of the recommendations, number 4, which particularly concern me, which is the need to adequately finance social services for people who are terminally ill. And I don't have a problem with financing social services for terminally ill. I just don't know why we should only finance social services for those who are terminally ill. We have a very serious problem in this country, which is over the last 20 years, with the growth in spending on Medicare and Medicaid as an excuse and the desire to cut taxes as the driving force, we have essentially eviscerated so-called domestic discretionary spending. And so the fact is, if you have a terminally ill Medicare patient who has serious nutritional needs that aren't being met and can't afford to meet them herself, and she lives in a community where there's already a waiting list for Meals on Wheels because of cutbacks in Title II funding under the Older Americans Act, she's got a real problem. But why should terminally ill old people be entitled to nutrition more than non-terminally ill, undernourished old people? The fact that either of those categories of folks exist is a disgrace, and we shouldn't hide it or ameliorate it or cover it up by saying, well, let's let Medicare pay for it. Because once you start down that slippery slope, I just got in this fight with my friend of mine. It's a very analogous situation, who's the health commissioner of the county of Los Angeles, who is developing supportive housing to get chronic homeless patients, most of whom have serious mental illness and or serious substance abuse, off of Skid Row, from which they are very heavy users of the emergency departments in his hospital and are often admitted into supportive housing. And the mean gremlins at CMS wouldn't let him make the cost of the supportive housing a reimbursable event, even though a reimbursable service, even though Mitch had the actuary show a number that they were saving Medicaid money. And I said, well, that's absolutely right, but we ought as a nation pay for housing. We'd have a lot fewer homeless people if we did. But once you open the gates and say that everything that conduces to the health of a Medicare or Medicaid beneficiary ought to be paid for them, there is no stopping. And we already have both houses of Congress saying we're spending way too much on Medicare and Medicaid already. We should cut $500 billion out of Medicaid in the next decade. This is not computing. We shouldn't play that game. We shouldn't fall into that trap. If we're not adequately financing social services for older people or other people in this country, we should fight to finance adequate social services. We shouldn't try to sort of sneak them into Medicare or Medicaid for a few years until somebody cuts the hell out of those programs as well. And as you can see, I feel sort of very strongly about that. But What we have done as a society for the last generation is essentially discontinue all other forms of human services spending in the United States while maintaining Medicare and Medicaid. And guess what? Now the same people are out to get Medicare and Medicaid. And they may succeed in part because they're going to charge that we're paying for all these things that were never intended to in the first place. So the way to respond to that is not to say, well, for these patients or those patients, we ought to pay for those services. The need to respond to that is say, for all Americans, we ought to pay for those services. Thank you very much.